Get it.
Okay. A 16-year-old girl, a 16-year-old girl is brought to the emergency department because of 3-day history of cough product 3-day history of cough productive of thick yellowish sputum and a 1-day history of shortness of breath. She has not had fever. She has a history of asthma treated with albuterol and inhaled corticosteroid, which she required hospitalization on 10 occasions between the ages of 8 and 10 years. She has smoked one and she has smoked 1 and 1.5 packs of cigarettes daily for 4 years. Her temperature is 37 degrees Celsius, pulse is 102 per minute, respiration 42 per minute, blood pressure 108 by 80 millimeter of mercury. Examination shows mild clubbing of the digit and increased anteroposterior chest diameter. Occasional end expiratory wheezes are heard on auscultation. A chest X-ray shows no abnormality other than severe bilateral hyperinflation. Which of the following is most likely diagnosis?
Hmm. Is it lower? Emphysema? Is it antitrypsin? Okay. Ready?
1 minute.
Is it antitrypsin or is it lobar emphysema?
Alpha 1 antitrypsin to happen, there may be liver problem, lungs and liver.
Yeah, that's what I thought. Okay,
But
so
there
it's
is no liver. And it is not cardiogenic because chest
yeah,
X-ray show no abnormality.
it's normal. I don't know what's pulmonary sequestration. I don't know
May,
what is
may
that.
not be the answer, but in sarcoidosis, bilateral hilar lymphadenopathy should be present.
Listen. Okay. Probably emphysema.
But we are wrong.
Oh my God, it's antitrypsin. I'm pretty sure. Let me
Okay.
see. The most likely cause of the findings in this patient is alpha 1 antitrypsin deficiency, inherited protease inhibitor deficiency. Alpha 1 antitrypsin normally regulates neutrophil elastase, which is a serine protease secreted by neutrophils and macrophages as part of a localized inflammatory response. Alpha 1 antitrypsin deficiency is an inherited disorder caused by mutations in the SERPINA1 gene, which encodes alpha 1 antitrypsin. Reduced activity of alpha 1 antitrypsin results in the host tissue damage from neutrophil elastase, especially in the lungs. Pulmonary manifestations classically include panlobular emphysema, especially in the lung bases. As suggested by this patient evaluation, the diagnosis should be suspected in a young patient presenting with evidence of chronic lung disease with bibacillar emphysematous changes. Patients are also at risk of chronic liver inflammation and cirrhosis because of the accumulation of misfolded alpha 1 antitrypsin polymers in hepatocyte. It is not B. Congenital lobar emphysema is a rare pulmonary disorder caused by disrupted embryonic bronchopulmonary development and is characterized by air trapping and lung hyperinflation, which can be visualized on chest imaging. The severity of disease varies widely and may be asymptomatic until adulthood or present in the newborn period with respiratory distress. Alpha 1 antitrypsin deficiency is more common. Okay. And pulmonary sequestration is a congenital lung malformation in which a segment of this plastic non-functional lung tissue is formed that does not communicate with the rest of the airway. Patients typically present with recurrent pneumonia in the same localized region. Other clinical manifestation include persistent cough, hemoptysis, exertional dyspnea, and back pain. I don't understand that, but okay.
Next.
Mhm.
A 5-year-old boy is brought to the office because of 3-day history of rash on his left leg. Rash on his left leg. He has had 5 previous skin abscesses that have required prolonged treatment. He was admitted to the hospital. He was admitted to the hospital for osteomyelitis at the ages of 2 and 4 years and pneumonia at the age of 3 years. His maternal uncle died of fungal pneumonia at the age of 5 years. The patient's temperature is 101. Examination show several enlarged tender inguinal lymph nodes. There is 2 to 3 centimeter warm erythematous macular rash at the lower extremity. Which of the following mechanism of the disease is most likely cause of this patient's symptoms? Ready?
No, tomato. So it's bacteria, skin abscesses, leukocyte adhesion, granulation, bone marrow, impaired leukocyte chemotaxis, impaired leukocyte microbacterial activity. Maybe adhesion. I'm not sure. Okay, ready. Oh, leukocyte microbacterial activity. CGD. Okay. Chronic granulomatous disease is a rare primary immunodeficiency syndrome caused by mutations in the gene coding for NADPH oxidase. It is inherited in an X-linked recessive pattern and results in defective intracellular killing of catalase positive pathogens because NADPH oxidase is necessary enzyme in producing respiratory oxidative burst. The impaired leukocyte microbacterial activity makes patients susceptible to recurrent pathogenic bacterial and fungal infection with organisms such as Staph aureus, Staph epidermidis, Serratia, Aspergillus candida. Symptoms often appear within the first years of life with recurrent pneumonia, lung abscesses, aspergillosis infection, skin abscesses, osteomyelitis, and chronic diarrhea. Physical examination may show hepatosplenomegaly, lymphadenopathy. Diagnosis is made by abnormal dihydrorhodamine test or nitroblue tetrazolium. Okay, there it is. Nitroblue tetrazolium reduction test. In the latter test, normal phagocytes use the action of NADPH to reduce nitroblue, which leads to a color change from yellow to blue. Patients with CGD will not demonstrate a color change. It's not abnormal leukocyte adhesion. And impaired leukocyte chemostaxis are implicated in the pathogenesis of LAD, leukocyte adhesion deficiency. It is typically characterized by recurrent bacterial infection. Impaired wound healing in delayed detachment of the umbilical cord after birth, and complete lack of neutrophils at site of infection with no post formation. And it's not abnormal leukocyte degranulation is observed in the Chidiac-Higashi syndrome. Clinical manifestations include frequent bacterial infection, ocular cutaneous albinism, peripheral neuropathy, progressive neurologic dysfunction. Leukocyte degranulation is normal in CJD. Okay, next.
So leukocyte degranulation is CGD, Shediac-Higashi syndrome, and abnormal leukocyte adhesion and impaired leukocyte chemostaxis is leukocyte adhesion deficiency. Okay. A 12-year-old girl is a 12-year-old girl has cramping abdominal pain, nausea, and 4 episodes of vomiting of past 24 hours. Over the past 2 months, she has been drinking Over the past 2 months, she has been drinking large quantities of the fluid and has urinary frequency. She has had 6.8 kg weight loss during that period. She appears tired but is alert and answer questions appropriately. There is diffuse abdominal tenderness and fruity odor to his breath. Which of the following is the most likely additional finding in this patient?
Hmm. What does she have? Diabetes?
Looks like,
Fruity odor. I feel like that's the key.
but there
Hmm.
is huge weight loss, 6.8 kg weight loss over past 2 months.
So, oh,
Or
I don't know. What does she has? Hypertension, neutropenia. I don't know. I don't know the diagnosis on this. Ready?
okay,
Crystal, what's the diagnosis? The patient with nausea, abdominal pain, and fruity odor to her breath has presentation cause DKA. Okay, DKA occurs most commonly in the setting of type 1 diabetes. It may be the initial presentation in a patient who has not yet been diagnosed. It's caused by accumulation of serum ketones such as beta hydroxybutyric acids, acetoacetic acid, and acetone in the setting of insulin deficiency or acute catabolic stressors such as infection. Yeah. Dysregulated fatty acid degradation and ketone synthesis occurs because of the relative state of starvation created by absent insulin signaling. Patients with DK may present with fatigue, polyuria, polydipsia, shortness of breath, tachypnea, and diffuse abdominal discomfort. Vital signs may show tachycardia, tachypnea, and hypotension due to severe hypovolemia, um, which occurs secondary to osmotic diuresis from hyperglycemia. Okay, Cosmos respiration, rapid and deep breathing pattern is classic physical exam finding due to respiratory compensation for the underlying metabolic acidosis. Patients may demonstrate physical examination signs of hypovolemia, dry mucous membrane, decreased skin turgor, along with sweet breath odor secondary to ketones. Lab analysis typically show increased serum glucose and ketones, metabolic acidosis, and high anion gap due to accumulation of unmeasured anions in serum. Okay. Metabolic acidosis is accompanied by decreased bicarb concentration in the serum, as bicarb is consumed in the neutralization of increased acid molecules in the blood. The initial management of DKA should focus on volume repletion with isotonic fluids, which is crucial to hemodynamically stabilize the patient, restore tissue perfusion, and clear ketones. Volume repletion should be followed by insulin, correction of electrolyte abnormalities, and treatment of any precipitating factors. Okay, next.
a 2-month-old girl is brought to the physician by her mother for a well child examination. 6 weeks ago, she had watery diarrhea with blood in her stool. At that time, she was switched from cow milk based formula, which she had been fed since birth, to a soya based formula, and the diarrhea resolved. She appears well. She is at 50 percentile length, weight, and head circumference. The examination shows no abnormality. The mother should be counseled about which of the regarding patients that.
Do they outgrow that? I don't know. Ready?
Yes.
So she will likely outgrow her milk protein intolerance. This patient initial presentation is consistent with cow milk protein intolerance. The underlying cause is hypersensitivity reaction to unknown um, non-native antigens in cow milk and is mediated by both Ig-dependent and non-Ig-dependent mechanisms. Cow milk protein intolerance (CMPI) presents in infants with colic, regurgitation, diarrhea, hematochezia, urticaria, rash, atopic dermatitis, and iron deficiency anemia. Severe cases may rarely present with failure to thrive, wheezing, and anaphylaxis. Um, the diagnosis is clinically confirmed with improvement in symptoms following elimination of cow meals from diet. In breastfed infants, elimination of cow meal from the mother's diet is also necessary. Contrast to lactose intolerance, CMPI resolved in half of children by age 1 year old and in nearly all children by age 5 years old. It is not B, bypass B. Lifelong milk protein intolerance is rare. The great majority of children will outgrow by 5 years of age. Or let me do A. Lifelong lactose intolerance is typical for patients affected by lactose intolerance. Lactose intolerance is a common off-heritable condition associated with inadequate expression of lactase. It is distant from it. This is different clinical entity from CMPI, although it presents similarly in children and adults with cramping, abdominal pain, bloating, flatulence, and diarrhea. Lactose intolerance typically presents at age 2 to 3 years of age, in contrast to CMPI, which presents in infancy. In further contrast, CMPI lactose intolerance is typically lifelong, while outgrow lactose intolerance is atypical. Okay, so you don't outgrow lactose intolerance, but you outgrow the cow milk thingy. Okay, got it. Next.
A 10-year-old girl is brought to the physician of 5-day history because of 5-day history of low-grade fever, mild generalized itching, fatigue, and 1-day history of rash that started over her face. Now involves her entire body. She also has mild rhinorrhea. She has not had abdominal discomfort or diarrhea. She recently immigrated to the USA and from Central Park with her family. Her temperature is 100. Examination showed discrete maculopapular lesion over the face, extremities, trunk, and the back. There are no ocular or oral lesions. Which of the following vaccine is most likely to prevent this patient's condition?
Fever, low-grade fever, itchy, fatigue, rash, the face and the entire body. No diarrhea, no. Amphibious, no. Hep B, no. Polio, no. Viral, no. Measles, mumps, and rubella, maybe. Pneumococcal, no. Typhoid, I forgot what was typhoid. Varicella, it has rash, but it's in the face. No, probably not. Severe pertussis, diphtheria, tetanus, no. Probably measles. Ready?
Yes,
Okay. Measles, mumps, rubella. Measles, rubeola. Measles. Virus is a highly contagious paramyxovirus that causes the disease measles, which is associated with acute febrile illness and potentially severe sequela. It's more common in children than adults, characteristically presents with prodromal fever, along with cough, chorea, conjunctivitis, and confluent maculopapular rash that starts in the head, neck, and spreads to the trunk, excluding the palms and soles. Excludes the palms and soles. Physical examination may show bright red macules with bluish with a bluish white center on the buccal mucosa. Okay. Complex spots and lymphadenopathy. Treatment is support. The complication of measles includes subacute sclerosing panencephalitis, which is uniformly fatal. Measles infection may be prevented with MMR vaccine, which is a live attenuated vaccine. CDC recommends vaccination with MMR in a two-dose series beginning at age 1 year old. So measles spares the hands and feet.
Maculopapular rash can this type of rash can happen in varicella also. Why it is not varicella?
Oh, let me read it. What is varicella? Where is varicella? Varicella vaccination prevents infection with varicella virus, which causes chickenpox in children and shingles in adults. Chickenpox does not typically present with conjunctivitis or chorea. But did this patient have conjunctivitis? Okay. The
No.
rash caused by chickenpox. Yeah, so why they keep okay. The rash caused by chickenpox is vesicular, it's not maculopapular. And characteristically begins on the trunk in contrast to descending maculopapular rash associated with measles. Okay, I think the chickenpox that doesn't include the face, and then it's vesicular.
Okay.
Okay, let me see paramyxovirus. Okay, yeah, doesn't include the hand and feet, I guess. Yeah.
Okay. Can we take
Okay.
5 minute break?
Yes, we can.
Okay. Welcome. Uh, a 7-year-old girl is brought to the physician. 7-year-old girl is brought to the physician by her mother because of 2 day history of burning sensation during urination. 2 day history of burning sensation during urination. She has been treated with nitrofurantoin for UTI on 2 separate occasion. Cultures at the time of the infections were negative. Urine examination show frothy vaginal discharge. The vulva is normal. There is small uterus. A wet mount preparation of the discharge showed Trichomonas vaginalis. Urine analysis show no abnormalities except for Trichomonas vaginalis. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
So, what happened? Assessment for sexual abuse. Trichomonas is an STI by Trichomonas that causes vaginitis, cervicitis in women and urethritis in men. Trichomonas commonly presents with vaginal pruritus, dyspareunia, cervical erythema, abnormal discharge that is green, frothy, and malodorous. Trichomonasis can lead to overactive bladder, frequency, urgency, and incontinence. As trichomonas is transmitted through sexual contact, a young child with trichomonas should be promptly evaluated for sexual abuse.
Okay.
Mhm.
A female a newborn is admitted to the NICU because of diffuse jaundice and petechial rash noted at birth. She was born at 35 weeks of gestation following spontaneous. She was born at 35 weeks of gestation following spontaneous vaginal delivery to 23-year-old woman, gravida 1, para 1. Pregnancy was complicated by fetal growth restriction. There is no family history of serious illness. There are no pets in the home. Examination of the patient is below third percentile for length, weight, and head circumference. Vital signs are within normal limit. Examination showed diffuse tenderness and petechial rash over head, trunk, and all extremities. No murmurs are heard. The liver edge is palpated 5 centimeters below the costal margin. The spleen tip is palpated 3 centimeters. Spleen tip is palpated 3 centimeters below the left costal margin. Lab studies shows hemoglobin 16, leukocyte count 8,300, platelet count 78,000, serum bilirubin 16, direct bilirubin 7.3, a CT scan of the head is shown, brainstem auditory evoked potential, shows sensorineural hearing loss bilaterally. Which of the following is most likely to confirm the diagnosis?
Mm, sensory neural hearing loss. Looks like
Cat- Rubella syndrome,
no. It looks like that for you.
cataract deafness PDA.
What is cataract?
Deafness is present.
No, it looked like CMV for me, but I don't know for CMV. Do
CMV
you,
cause retinitis. There is no eye finding.
but do you see the pattern in the
Yes,
image? It's like periventricular, right?
yes, it looks like periventricular. That's true.
So is it viral culture or is that lymphocyte enumeration or something? I think it's viral. I don't know.
Is there anything called viral culture?
I don't know. It doesn't look. No, I never heard that. But I mean, they only seem viral. That's so. Is it lymphocyte enumeration?
But direct. Okay, okay, you may be right. I don't know actually.
Okay, let's see. Uh,
Confirm.
it is
MRI.
viral. I guess
Viral.
yeah. There is urine viral culture. Yeah, yes,
Okay.
that's the way. This neonite presents with findings consistent with CMV. CMV, also known as HHV6, belongs to the family of herpes virus and possesses a large double-stranded DNA genome. Congenital CMV infection presents with intrauterine growth restriction, microcephaly, intracranial calcification, hearing loss, seizures, hepatosplenomegaly, jaundice, thrombocytopenia, and petechial rash. The diagnosis is confirmed with viral culture of or polymerase PCR, polymerase chain amplification from urine or blood within the first week of life. It is the most common cause of non-hereditary sensorineural hearing loss. In about 10% of cases, hearing loss may be an isolated finding without other symptoms of infection present. Hearing loss is also the most common sequela of an initially asymptomatic neonate. Fetal hydrops is a potential complication of CMV, although it's less common than with parvovirus. Intracranial calcification demonstrates a characteristic periventricular distribution and may be detected by ultrasound of CT. Pregnant women most often contract CMV through exposure from young children, often through daycare centers. A primary maternal infection has a high risk for vertical transmission via placenta to fetus. Treatment is with antiviral agents such as ganciclovir and valganciclovir. It is not lymphocyte enumeration by flow cytometry is useful for diagnosis of primary immune deficiencies. While infants with immune deficiency may present with recurring infections, congenital infections with associated abnormalities suggest a alternate diagnosis. Okay, next.
A 1 month old male. A 1 month. Sorry. A 1 month old male newborn is brought to the emergency department because of 2-day history of forceful non-bilious vomiting. I'm coming within 1 minute.
Okay. Okay.
Hello, are you there?
Hello.
Yes, can you
Oh,
hear me?
okay. Yeah, I can hear you now. Yeah, I can hear you. Can you hear me?
Yes, I can hear you. Okay, I was reading the question. A 1 month old girl, uh, a 1 month old newborn. Okay, I don't know what is wrong in my laptop.
Mm.
Something happened in the laptop. I need to restart.
You need to start it? Okay.
Okay.
Yeah.
A 1 month old girl, sorry, a 1 month old newborn is brought to the emergency department because of 2-day history of forceful non-bilious vomiting. His mother reports that the vomiting has been getting worse and that he now seems irritable and acts hungry afterward. He was born at term weight 2.9 kg. There were no prenatal or perinatal complication. He has not had any sick contents and does not attend daycare. His mother underwent pyloromyotomy as infant. The patient's current weight is 2.8 kg. His temperature is 37. Pulse is 180 per minute. Respiration 36 per minute. Blood pressure 60 by 40 millimeter mercury. Pulse oximeter on room air oxygen saturation is 99%. On physical examination, the anterior fontanelle is sunken. A mucous membrane are dry. Which of the following sets of electrolyte findings is most likely in this patient? Whatever, madam, alcohols, damage.
Ready?
Yes,
Mm. What is it? So it's B. Pyloric stenosis is caused by hypertrophy of the pyloric sphincter, leading to gastric outlet obstruction and vomiting. It commonly presents with non-bilious emesis after feedings, beginning around like 3 of age. I guess 3 to 6 months, I guess, and is more common in male infants. Symptoms may begin with occasional vomiting, then progress to projectile emesis after every feed, dehydration, malnutrition, and stenosis as the stenosis worsens. Repeat bouts of vomiting can cause metabolic and electrolyte derangements, classically hypochloremic, hypokalemic metabolic acidosis, metabolic alkalosis, sorry, caused by loss of hydrochloric acid, a major component of stomach secretions. Metabolic alkalosis occurs secondary to dehydration and subsequent volume contraction plus relative excess of bicarb. Volume depletion also leads to activation of RAS, which in turn stimulates kidney tubules bicarbonate reabsorption and new bicarbonate generation. Metabolic alkalosis volume depletion in increased concentration of aldosterone also leads to renal potassium excretion. Okay. And hypokalemia. Hypokalemia 4.7, but here is normal. Hypokalemia also contributes to metabolic alkalosis via transcellular exchange of extracellular sodium and potassium for potassium ion. Diagnosis of pylori stenosis is typically by abdominal ultrasound, which shows a thick pyloric musculature, and treatment is with surgical pylorotomy. A demonstrates isolated hypochloremia. Hypochloremia most commonly occur with metabolic alkalosis as chloride is excreted in exchange for reabsorption of bicarb. This bicarb is normal, making this incorrect profile for patient with bicarb. Yeah, yes.
Okay.
Okay.
A 17-year-old boy is comes to the physician one day. History of swelling of his right hand. The swelling begins 6 hours after he was involved in a fist fight at school. On questioning, he says he hit his opponent, his mouth and abdomen. Examination show erythematous in the dorsum of the right hand. There is small laceration of the fourth metacarpophalangeal head. Which of the following organism is most likely cause of these patients' symptoms?
Sorry. Metacarpal head. Aerobic gram positive total. Aerobic
Yes,
gram. One moment. Okay, ready.
yes,
So it's mixed flora. Human bites are associated with mixed oral flora and skin flora, including Staph aureus, Strep pyo, Echinella corrodens, and various anaerobes. Human bites may be accidental, intentional, or the result of clenched fist injury. When the skin barrier is interrupted, these injuries are at high risk for infection, often with multiple organisms. Signs of superficial skin infection include tenderness of the affected site, redness, swelling, purulent drainage, and potentially fever. Affected patients should be evaluated for the development of infection at the site of injury. In general, these wounds should be irrigated and left open due to the high risk of infection. The first-line antibiotic of choice for infected human bites is amoxicillin clavulanate acid. It's not A and B. Aerobic gram-positive cocci, including staph and strep, along with anaerobic gram-positive cocci, including strep, are commensal organisms that may be present and associated with additional oral and skin flora in secondary infected human bites. Okay, next.
a 9 a 9-month-old boy is brought to the emergency department by his mother, who reports 9-month-old boy is brought to the emergency department by his mother, who reports that he injured his right thigh 2 hours ago. He injured his right thigh 2 hours ago when he slipped on a wet floor. Examination of the right thigh showed tenderness and swelling. Range of the motion of the right hip is limited. An X-ray of the right lower extremity show spiral fracture of the femur. Which of the following is the most appropriate next step in the management?
fracture. Mm, spiral fracture, spiral fracture. I forgot. Ready?
Yes.
So it is notification of CPS, Child Protective Services. This infant with spiral fracture after sleeping on a wet floor has presentation concerning for child abuse. There are several red flags that should alert medical providers of potential child abuse, including a history inconsistent with type of injury present, mechanism of injury inconsistent with child physical ability, a 3-week-old infant roll off the bed, and delay in presentation. Certain physical examination findings such as retinal hemorrhage, bruises on the ear, trunk, neck, and certain burn patterns, circumferential hand or foot distribution, cigarette burns should also alert the provider to potential abuse. Fractures of posterior ribs, metaphyseal corner fractures, and subdural hematomas in an infant are also suspicious imaging findings. Spiral fractures typically occur when a rotation of force is applied, such as twisting of the limb. This infant has an injury that is inconsistent with the history that is given, and CPA should be notified immediately. Okay.
Okay. Weight 2 kg, 2000 gram, female, newborn, is jittery. She was born at 35 weeks of gestation, a 16-year-old primary gravid patient. The membrane ruptured 6 hours after delivery. Her rectal examination is 35 degrees Celsius. Examination shows no abnormality except increased irritability. A Hale stick blood glucose concentration is 35 mg per deciliter. After administration of the glucose, water, a repeat Hale stick blood glucose concentration 40 mg per deciliter. Blood is drawn for blood count and culture urinalysis and CSF and ordered. Which of the following is appropriate pharmacotherapy in this newborn?
Jittery. Hmm.
Ready?
No, can you figure out what the C has?
This is neonatal sepsis, isn't it?
Oh, oh. So if it's sepsis, it's probably group B strep, and if it's group B strep, it's probably penicillin. Okay, ready. Oh, never mind. This preterm newborn, let me write it here. This preterm newborn presents with hypothermia and hypoglycemia, indicating neonatal sepsis. Neonatal sepsis is most commonly caused by bacterial infection and presents with fever or hypothermia, hypoglycemia, lethargy, irritability, simple feeding. Evaluation should include a CBC, blood culture, urine culture, as well as testing and culture of the CSF. Common microbiological causes of neonatal sepsis include E. coli, Strep agalactiae or Group B, and Listeria monocytogenes. Risk factors for the development of neonatal sepsis include preterm birth, preterm birth, low birth weight, premature rupture of membranes, and maternal infection. Okay, the most common pathogen associated with early onset neonatal sepsis is considered group B strep, so strep agalactiae, but the frequency of sepsis from this has decreased through routine use of intrapartum antibiotic therapy for mothers that test positive for it in the antepartum period. Neonatal sepsis is treated with ampicillin and gentamicin for appropriate broad spectrum coverage. It's not E. What is E? Right here. Penicillin G commonly used to treat syphilis. G. Tobramycin is an amicocide antibiotic like gentamicin. However, penicillin G and tobramycin are not first-line treatment for sepsis. So it's ampicillin and an aminoglycoside. Okay.
A 12-year-old girl is brought to the physician. Follow-up examination. She has 3-month history of moderate asthma. Pulse 90, respiration 20, blood pressure 110/70, diffuse expiratory wheezes bilaterally. Which of the following is the most appropriate initial pharmacotherapy? Which of the following is most appropriate initial pharmacotherapy for this patient?
Ready?
Yes.
So it's inhale steroid daily and inhale short-acting beta agonist as needed. Where am I? Asthma, a reversible obstructive lung disease, presents with shortness of breath, cough, tachypnea, increased work of breathing, and wheezing on exam. It is often triggered by exercise, allergen, illness, and smoke. It's characterized by a reversible bronchospasm, which causes obstruction of airflow. Generally, exhalation is affected more than inhalation. The diagnosis is based on clinical history and exam and confirmed through PFTs, pulmonary function tests, which reveal an obstructive panel characterized by decrease in FEV1 and decrease FEV1 FVC ratio and preserve FBC. Asthma can also be diagnosed on based on the reversibility of bronchospasm using beta agonists and methacholine or methacholine, with PFT demonstrating alleviated or exacerbated obstruction. Treatment depends on the severity of asthma, but initial treatment should include low dose inhaled steroids daily, often in a combination with inhaled short acting SABA beta agonists as needed. It is no longer recommended to treat asthma with SABA alone as it can lead to overuse and treat only the symptoms rather than the underlying. Oh, did not know that. Okay, that's new. And it's not B. Inhaled short-acting SABA can be included in the initial treatment regimen for patients with asthma, but should not be the only treatment as it can lead to overuse and related risk. Mm, okay. So right now you don't start with just with SABA. You start with inhaled steroids and SABA. Okay. Next.
A 10-year-old girl is brought to the physician for her child examination. She was recently adopted from an orphanage in Eastern Europe. Her parents were informed that she was unrepaired congenital heart defect, but further details are not available. Growth and development are appropriate for age. Her pulse is 96 per minute, respiration 24 per minute, blood pressure 102/66. In the right, 102/66 in the right upper extremity, 114/72 in the right lower extremity. Pulse pulse oximeter in the room mirror is oxygen saturation is 93%. Cardiac examination show a hyperdynamic precordium with a right ventricular impulse. There is loud, narrowly split S2, a grade 2/6 early mid-diastolic murmur heard at the left sternal border. The liver edge is palpated 2 cm below the right costal margin. Brachial and the femoral pulses are normal. ECG show right ventricular hypertrophy. The most likely mechanism of this patient's condition.
Link normal. Lower left sternum. Patients take money. Take tricuspid. Tricuspid regurg. Mm, Systemic cardiac output. Systemic vascular resistance. Systemic vascular resistance. Systemic. Mm, Narrow split. Ah, think.
Just thinking that way, like ECG shows right ventricular hypertrophy, isn't it? So
Mm,
how right ventricle is hypertrophied? From the
no.
right ventricle, through pulmonary artery, blood goes to the lungs, isn't it?
Also, you think it's pulmonary vascular resistance?
Yes, I am thinking on that.
Okay. Let's check. Yep, you are right. VSDs, oh, it was VSD, are among the most common congenital heart malformations. The genetic cause of VSD is heterogeneous and includes non-association with well-defined symptoms such as the George or Down. It may also occur in isolation and via non-specific random mutations and in individual point mutations that are de novo. VSD are characterized by holosystolic murmur best heard in the left lower sternal uh, border and may have an associated pulmonary. Yes, these result in a left to right shunt, which increases pulmonary blood flow. This leads to the remodeling of the pulmonary vasculature and resultant smooth muscle hypertrophy. In turn, concentric narrowing of the pulmonary arteries occurs, which results in the development of pulmonary arterial hypertension. If severe and progressive enough, this can cause increased right ventricular pressures and associated myocardial hypertrophy, which can be associated with narrow split S2 because of timing of closing of pulmonary valve, right ventricular heave, and signs of right heart failure, such as lower extremity edema, hepatomegaly. This patient has evidence of right-sided hypertrophy because of increased pulmonary vascular resistance. In the set, what am I reading? In this pulmonary resistance, in the setting of long-standing left to right shunt. If this patient VSD goes uncorrected, increased right sided pressures can subsequently lead to reversal of the shunt, presenting with shortness of breath and cyanosis, some of which may already present in this patient whose oxygen saturation is 93. Central CVP increase often occurs in the setting of right-sided heart failure and volume overload. This patient's CVP is likely increased given her intracardiac shunt and pulmonary hypertension. However, her physical examination findings are primarily secondary to PVR in the setting of long-standing VSD. An increased CVP will be secondary to her pulmonary hypertension, not the cause of the pulmonary hypertension. And it's not systemic vascular resistance. Increases are not responsible for this patient condition. Systemic SVR may increase in response to decreased seal or in response to hypoxia to maintain perfusion of distal organs. However, an increased SVR will not cause right-sided heart failure seen in this patient. Okay.
Okay,
Okay.
a previously healthy 2-year-old girl is brought to the physician because of 2-day history of fatigue, red spots over the body. 2-day history of fatigue, red spots over the body, facial swelling. During the past 24 hours, She has urinated twice, although she has been drinking well. 7 days ago, she had fever, bloody diarrhea. She received supportive therapy, and her father and the diarrhea has resolved. Today, she appears pale and her temperature is 98, pulse 160 per minute, respiration 26 per minute, blood pressure 120 by 80. Examination shows mild generalized edema. Lab hemoglobin 7, leukocyte 12,000, 12,000, platelet count 30,000, PT 11.5, PTT 32 normal. Sodium is low 129, potassium is high 5.9, chloride is normal, bicarbonate is low, blood urea nitrogen maybe normal, and creatinine is 3.2. 1 plus blood protein and RBC is absent. Which of the following is most likely diagnosis?
Mhm. PTT. Most likely. Oh, I know it's HOS, but is it decrease in intravascular volume or is it toxin mediated?
Toxin measure, isn't it? E. coli 015787.
Yeah, right. Yeah.
I'm thinking.
Yeah, it makes sense. Okay, let's check. Yes, toxin mediated. Um, this patient presentation with recent fever and bloody diarrhea and subsequent development of oliguria, suggestive of HUS. HUS often presents in children and is commonly caused by E. coli 0157H7, also known as enterohemorrhagic E. coli, produces a sugar toxin that damages intestinal wall, which initially causes hemorrhagic enteritis or bloody diarrhea. This toxin additionally damages the endothelium, which may lead to subsequent microangiopathic anemia, thrombocytopenia, and acute kidney failure. Okay, in HOS. Treatment for uncomplicated cases is supported with oral and IV hydration, and it's recommended that antimotility and antibiotics are avoided. It's not in decrease in intravascular volume is associated with dehydration and perirenal azotemia. Perirenal azotemia is associated with an increased urea creatinine like 20 ratio, urea creatinine ratio 20. In severe cases, of volume depletion, hypovolemic shock can result, demonstrated by tachycardia and hypotension. It doesn't have tachycardia and hypotension. BUN creatinine. So it will be 30 over 30.2. Let me see. 30 over 3.2. 9 point. Okay. Next. Omar, you still there?
Yes.
Okay.
A 12-year-old girl with a 5-year history of type 1 diabetes mellitus is brought for a follow-up examination. Over the past 4 weeks, she has had persistent sweating, shakiness, and a pallor despite 60% decrease in her insulin doses. Her blood glucose concentration continued to range between 40 to 59. Her examination, her exercise regimen and dietary intake have not changed. Examination shows no abnormality. Serum studies shows sodium 137, chloride 102, potassium 4.2, bicarbonate 24, glucose 45, insulin increased, C-peptide not detectable, glucagon increased, cortisol increased. Which of the following is the most likely cause of this patient's finding?
Ready?
1 minute.
Okay.
Okay.
Okay. So it is uh, excess exogenous insulin. Let's see. This patient presents with symptoms of hypoglycemia, which are generally neo- neuroglycopenic agitation, headache, blurry vision, diplopia, tremor, loss of consciousness, and autonomic sweating, tremor, nausea, vomiting, camping, um, tachycardia, anxiety, and non-specific fatigue, weakness, lethargy, often exacerbated by periods of fasting or exercise. Um, the lab evaluation shows increased insulin concentration and undetectable cyst peptide concentration, most likely pointing the administration of exogenous insulin as the cause of hypoglycemia. Insulin synthesis occurs in the beta cells of the pancreas. Pre-proinsulin synthesized in the rough endoplasmic reticulum is cleaved into proinsulin, which is stored in the cytoplasmic granule. Prior to secretion, proinsulin is cleaved and insulin and C-peptide are released in equal amount into the circulation. Hyperinsulinemia due to endogenous secretion is therefore associated with increased C-peptide concentrations, whereas hyperinsulinemia caused by administration of exogenous insulin is not. This patient may have low C-peptide concentration due to loss of endogenous insulin synthesis. However, her hypoglycemic episode should have resolved with decreased insulin dosing, and they have not, despite a lack of another clear cause of hypoglycemia, raising the likelihood of excess exogenous administration.
I don't get. Can you explain?
I don't get the last sentence, but for me, I got it because see, if it's an insulinoma, um, insulin should be increased and C peptide should be increased. So every time the insulin comes from your body, C peptide needs to be increased. So here it just gave it away. The fact that they say that C peptide is not detectable but insulin is increased, that means that it's not insulin from your body. So it must be that he's injecting. Now I don't get this sentence where it says that this patient may have low C-peptide concentration due to low endogenous insulin synthesis. However, her hypoglycemic episode should have resolved with decrease. I don't understand this last sentence, but yeah, that's how I got it, just because of the C-peptide thing.
Okay. If it is endogenous insulin production, then C-peptide would be increased.
Because it's coming from the body, endogenous from the
Yes.
body, yeah.
So, okay.
hmm Say it. You wanted to ask something else?
No.
Okay.
A previously healthy 10-year-old boy is brought to the emergency department 2 hours after the onset 2 hours after the onset of the pain in her right knee. She also has decreased appetite for 12 hours. There is no history of trauma. There is no history of trauma to the knee or pain. Her temperature is 102. Examination show erythema, swelling, warmth of the right knee. Passive range of motion of the knee is limited by pain. and the associated muscles are in spasm. She walks with an obvious limp. Which of the following is the most likely diagnosis?
Is it septic arthritis or is it osteomyelitis? Increased appetite. I don't know. Ready?
Yes.
Is septic arthritis. Let me read that from here. This patient with red, swollen, and painful knee with associated decreased range of motion has presentation consistent with septic arthritis. Septic arthritis results from bacterial infection of the synovial joint space, most commonly by Staph aureus. And classically presents with joint pain, worse with blooding, ranging and use, swelling and overlying redness. Children, immunocompromised patients, those with a history of traumatic injury to the joint, and those with existing abnormal joint anatomy like rheumatoid or gout may be commonly affected. The mechanism of infection may be direct inoculation, hematogenous spread, or extension from a neighboring local infection like osteomyelitis. Vital signs may show fever, tachycardia. Physical exam classically shows red erythematous, red edematous joint with a palpable effusion and tenderness elicited on range of motion or palpation. If direct trauma preceded the infection, a wound or laceration may be present in association with joint findings. Lab analysis typically show leukocytes along with increased ESR, CRP, arthrocentesis is essential to diagnose septic arthritis and to differentiate the condition from osteoarthritis and inflammatory arthropathies, such as gout and rheumatoid arthritis. Synovial fluid can also be sent for culture and gram stem plus sensitivity testing of the offending organism, permitting the target treatment. Leukocyte count of synovial fluid generally greater than 50,000 and predominantly neutrophils when the infectious agent is the bacteria. Treatment includes broad spectrum antibiotics and often arthrocentesis, which with operative irrigation and debridement is necessary. It's not osteomyelitis, it's an infection of bone and bone marrow. Patients typically complain of pain, difficulty bearing weight, and overlying redness. This patient examination is more suggestive of infection of the joint space rather than adjacent bone. The osteomyelitis doesn't have fever, it's just pain, difficulty wearing, and erythema. Okay, next.
An 18-year-old woman is brought to the emergency department 1 hour after she attempted suicide by ingesting hydrochloric acid solution. She has substantial chest pain. Her temperature is 99.7 degrees Fahrenheit. Pulse is 110 per minute. Respiration 20 per minute. Blood pressure 135/85. The lungs are clear to auscultation. Abdomen is soft, non-distended, non-tender. Bowel sounds are normal. Which of the following is the most appropriate next step in the management?
Oh, never know those questions. Ready?
Yes.
Okay. So esophagoscopy. Ingestion of caustic substances may occur accidentally, like in young children, or intentionally and can cause significant damage to esophagus and stomach. Ingestion of strong alkali pain in common household cleaning products and drain cleaner is most common and results in liquefied necrosis. Acid ingestion is less common and leads to coagulative necrosis. Clinical presentation varies and depends on the amount of and type of substance ingested. Patients may present with oropharyngeal and epigastric pain, dysphagia or donophagia of drooling. If the upper respiratory tract is involved, the patient may present with stridor, um, hoarseness, and difficulty breathing. Early complications include esophageal and gastric perforation. A later complication may include bleeding and formation of fistula and strictures. Mm, Okay, initial management in the ER includes respiratory support, resuscitation, and pain control. If there is concern for perforation, chest and abdominal CT scan should be performed immediately in conjunction with surgical consultation. All patients should have esophagoscopy and upper endoscopy performed 48 hours after ingestion to assess the extent of damage and guide further management. It's not, let me recall the other ones. Administration of sodium bicarbonate solution is unlikely to be helpful as mucosal injury occurs immediately upon ingestion of the substance. Furthermore, neutralization causes an exothermic reaction that releases heat and may lead to further mucosal damage. Barium solid should be avoided in early period following ingestion, as barium can cause mediastinal inflammation if perforation is present. If perforation is suspected, a water soluble agent can be used for evaluation. CT scan of the chest can be performed. Um, Patients with perforation may present with severe chest and abdominal pain, subcutaneous emphysema, and severe abdominal tenderness with rebound guarding and rigidity. This patient with soft abdomen, normal vital signs is unlikely to have perforation. Placement of nasogastric tube should be avoided in patients with ingestion as it may induce retching and vomiting, which can worsen the mucosal injury and increase the risk of esophageal perforation. Okay, next.
Okay. Look at the picture and tell me your diagnosis.
No. Okay.
If I were
It's
okay, what is your
oh,
diagnosis?
no. Between Scalded Skin and Steven Johnson. I'm between those two. Now read the question.
If I were old boy is brought to the emergency department because of one day history of fever, nausea, vomiting, pain during urination, a widespread red bumpy rash 3 days ago, she began amoxicillin therapy for exudative pharyngitis. He appears ill. His temperature is 39 degrees Celsius. Pulse is 120 per minute. Respiration 20 per minute. Blood pressure 95 by 48. Photograph of the rash is shown. There is anterior cervical lymphadenopathy bilaterally. Examination shows bilateral conjunctival erythema and photophobia. There are several 3 to 5 oral ulcers. Which of the
Hmm.
following is the most likely diagnosis?
No, I'm not sure. I don't think it's that. No, I'm between Kawasaki and Steven Johnson. He had exudative pharyngitis. Exudative, and he took amoxicillin. Oh, my lord.
Look at the lip of these children. If mucocutaneous involvement, like if the tongue, oral mucosa involved, think about SGS or TAN, sorry, TAN.
Hmm.
But
Okay.
like
But the lymphadenopathy would that also be? Wouldn't that go more with Kawasaki?
it is not Kawasaki disease.
It's
Kawasaki
not.
disease has a certain criteria:
Okay.
conjunctival rash, adenopathy, mm, like crash and burn. There is a mnemonic called crash and burn.
There is also conjunctival right rash here. Okay.
but it happens after taking drug.
Okay,
Kawasaki
yeah, that's
Kawasaki is
true.
a vasculitis,
That's true. That's
and in
correct.
Kawasaki disease fever more than 5 days. This is 1 day fever. He is on amoxicillin. Then this
Yeah.
happened. Okay.
So it is Steven Johnson. Steven Johnson syndrome is a severe multi-cutaneous drug. Oh, what happened with my screen? Is a serious severe multi-cutaneous drug reaction that may progress to 10 toxic epidermal necrolysis with an accompanying high mortality rate. SGS and 10 are distinguished from each other based on the amount of body surface area involved. Less than 10% for SGS and more than 30% for 10, and are driven by the same underlying pathophysiology. Common drugs implicated in development of SGS or 10 include beta-lactam antibiotics, antiepileptics, sulfur-containing medication, including TLP, SMX, NSAID, and allopurinol. SGS and 10 are characterized by confluent areas of dusky red, areas of dusky erythema with disformation of the epidermis. It can be distinguished from a morbilliform rug eruption by the presence of skin pain, disformation, mucosal involvement. SGS and 10 um, are often complicated by infection of the denuded areas of skin. Thus, meticulous wound care, preferably by a burn unit, is critical. The first step in treatment is to identify and discontinue the offending agents. Supportive care in a burn unit setting has been shown to improve mortality. But the role of other agents, including systemic steroids, cyclosporin, and IVIG, are controversial. It is not Kawasaki multisystemic vasculitis disease in children characterized by fever for at least 5 days, bilateral non-exudative conjunctivitis, non-exudative, polymorphous rash, lymphadenopathy, redness and edema of the hands and feet, and um, redness affecting mucocutaneous, erythema affecting mucous membranes with dry cracked lips. Complications include coronary artery aneurysm, and patients are managed well. It's not scarlet fever associated with group A strep pharyngitis infection and may present with red tongue and red rough papular sandpaper-like rash, disformation of hands and feet. And it's not, let me something else. Yeah, there was something else I wanted to read. Oh, staph scarlet skin syndrome. Occurs due to release of exfoliative toxin from Staph aureus, most commonly present in children and immunosuppressed adults with a diffuse erythematous rash that starts in the skin folds and perioral area, then progresses to generalized superficial disformation associated with fevers and malaise. Okay, next.
An 11-month-old boy. An 11-month-old boy is brought to the emergency department because of 2 day history of fever, cough, and rash. 2 day history of fever, cough, and rash. He was born at term and uncomplicated pregnancy and the delivery. He has had frequent otitis media since birth and was hospitalized at the age of 6 months for meningitis. He is at 10 percentile per length and 5th percentile per weight. Temperature is 102. Pulse is 140 per minute. Respiration 40 per minute. Blood pressure is 86 by 56. Examination show erythematous scaly rash. Erythematous scaly rash with several weeping lesions over the trunk and extremities. There are bilateral scarring of the tympanic membrane, bilateral scarring of the tympanic membrane, and dried blood and crusty material in the ears. Dried blood and crusty material in the ears. Decreased breath sounds are heard on the right. Lab studies show hemoglobin 10.3, hemoglobin 10.3, leukocyte count 12,400, and platelet count is 75,000. And X-ray of the chest show Right middle lobe consolidation. Which of the following is the most likely diagnosis?
Eczema. No. Skid. Elegant. Small. Oh, is it HIV? It doesn't make sense. Or is it skid?
Or it is Wiskott Aldrich. In Wiskott Aldrich, there is mutation in the VAS gene, recurrent infection, thrombocytopenia, eczema.
Thrombocytopenia. Eczema. Okay.
What is
Okay.
your diagnosis? I am thinking about SCID because platelet count
It's low,
low
yeah.
and it does not match with any other.
Yeah, it doesn't match with anything else. HIV, there is no lymphadenopathy, and what the rash doesn't make sense. Chronic granulomatous meningitis, whatever. It will be the catalase positive, but otitis media is strep pneumo. It's not catalase positive. Severe combined immunodeficiency,
Is B and T cell deficiency.
BNT cell, maybe, but I feel like it, yeah, maybe. And the George, I feel like he will have some calcium issues.
Yes.
Yeah, so maybe you're right in his whiskers. Okay, let's check. Yep, it's Wiskott. Wiskott-Aldrich syndrome is caused by mutation in the WAS gene on the X chromosome that encodes a protein essential for actin cytoskeleton rearrangement that occurs during interactions between T lymphocytes and antigen-presenting cells and B lymphocytes, um, leading to an impaired innate and adaptive immune response. Um, Immune system. The phenotype is variable and patients can present with eczema, thrombocytopenia, and infections with encapsulated bacteria and opportunistic pathogens. Okay. Encapsulated bacteria such as strep pneumo can cause otitis media, pneumonia, meningitis, in which we call Ladrich syndrome. Eczomatous rashes may be seen in many genetic disorders, including atopic dermatitis, Job syndrome, and Wiskott-Aldrich. Okay. And it's not HIV typically presents with systemic inflammatory symptoms such as fever, chills, night sweat, fatigue, weight loss, and sore throat. Safe SCID can result from numerous mutations, but commonly presents with recurrent bacterial, viral, and fungal infection due to severe impairment in both B and T cell function. Okay, so it's encapsulated bacterial, opportunistic infection, thrombocytopenia, and eczema. Next.
Okay. A 16-year-old boy is brought to the physician for a follow-up examination 6 months ago. He noticed a lump in the right testicle after practicing a soccer game during which he sustained a kick to the groin, and ultrasonography 2 days later showed a cystic lesion consistent with trauma. He was advised to avoid contact sports for 2 weeks and was told that the lesion would resolve without treatment. The patient reports that the patients report that since that time the lump was increased in size. The lump was increased in size and has become firm. He also reports facial acne, swelling of his breast, a stretch mark over the abdomen, and 4.5 kg weight gain despite uh, eating no more than usual. He has not had respiratory, gastrointestinal, or urinary symptoms. He appears well. Vital signs are within normal limit. Examination shows facial acne. There are striae over the lower abdomen. A firm, fixed 6 centimeter non-tender mass is palpated in the right testicle. There is no inguinal lymphadenum with a measurement of which of the following is the most appropriate next step in the diagnosis.
Ready?
Yes,
So is serum alpha fetoprotein and beta oxygen, HCG concentrations. Testicular cancer most often occurs in those who were assigned male at birth, either during adolescence or before 40 years of age. Presents with painless, firm nodule in the testes, which is commonly asymptomatic, although it can also present with a dull ache in the surrounding region. Patients may report first noticing the lesion following testicular trauma. Testicular tumors may be categorized as germ cell tumors and non-germ cell tumors. Germ cell tumors comprise most testicular cancer and include seminoma, choriocarcinoma, and teratoma, yolk cell tumors, and embryonal carcinoma. Non-germ cell tumors are often sex-cord gonadal stromal tumors originating from Sertoli Leydig cells. Risk factors for development of germ cell tumors include cryptorchidism, family history, seminiferous tube like Klinefelter syndrome, heavy marijuana use. Lab evaluation will often reveal increased concentration of LDH, mm, alpha fetoprotein, beta ICG, the last of which can cause gynecomastia depending on the subtype of testicular cancer. Ultrasound is the initial step in evaluation of palpable testicular mass. Malignant neoplasm will show heterogeneous mass with solid and cystic components, sometimes including calcification. Initial metastatic spread is commonly to the para-aortic lymph nodes. Treatment requires orchiectomy with possible retroperitoneal lymph node dissection and chemotherapy, depending on the presenting stage. Okay, next.
the mother of 12 the mother of 12-hour-old newborn expressed concern about the shape of his head. He was born at term after an uncomplicated pregnancy. In the second stage of the labor was 18 hours and low forceps were used to complete delivery. Apgar score were 8 and 9 in 1 to 5 minutes respectively. Temperature is 36.8 degrees Celsius, pulse is 128, respiration is 32. He appears vigorous and alert. Examination show prominent molding of the head. There is boggies 5 to 7 centimeter area of swelling that extend across the sagittal suture from the right parietal occipital area of the left parietal area. Which of the following is the most likely diagnosis? Extend the sagittal suture.
Remember you had made a mnemonic for that. I forgot. Ah, you had made a mnemonic last time.
I actually forgot what
Yeah,
I
the
about
one that extend past the suture and the one that didn't. Oh my lord.
extend. Okay, wait.
Oh, oh Jesus. Ready?
Yes.
Okay. So it is caput susadium. Caput susadium is a benign condition that is succedaneum, never mind. That is caused by peripartum trauma to the infant scalp. It is characterized by the development of edema and or hematoma in the subcutaneous tissues of the scalp above the galea.
Succedaneum is success, which is above the gallia.
Okay. But how do you differentiate the one that crosses? Because here we didn't need to know. We need to know that it crosses the suture or not.
If something pass out the suture, that is it. Okay, leave
Had
it.
made, you had. I feel like you had made in the body last time you
Yes,
made
I
something.
made it, but
Ah,
I don't remember
no.
now.
Because it's above the periosteum, it will cross the suture lines. Ah, and presentation is typically during delivery or shortly after. Physical exam will demonstrate bulgy or fluctuant area of soft tissue swelling that crosses suture lines and can cross the midline. Calcium is self-limited and resolves within 2 days. Cephalomatomas are traumatic subperiosteal hematomas that can occur with routine vaginal deliveries or those assisted with vacuum or forceps. They present they present several hours after birth with firm or fluctuating non-tender scalp swelling that does not cross the suture line, limited to one cranial lobe. They are usually self-limited and resolve spontaneously within like 2 weeks to 3 months, but can develop complications including calcification of the hematoma with prolonged bony swelling and cranial deformities, infection, and osteomyelitis. Unconjugated hyperbilirubinemia can occur due to the resorption of extravasated blood products. Oh, maybe let's just remember the cephalohematoma and then everything assists.
So,
The cephal-
in cephalhematoma, what is the significant thing?
like it doesn't cross the suture line, and then it's the one that can cause a lot of complications, like the unconjugated hyperbilirubinemia and infection and all that. The other one is so looks more benign than it crosses, looks more benign. So just remember the cephalohematoma is the one that's bad and doesn't cross the suture line and blah blah blah. If it's not that, then it's the other one. I don't know how you remember that the other name, but the other one. I don't know.
Okay,
Okay. I don't think there is a mnemonic on your word for that. I don't know. Maybe.
sorry,
I don't know if there is a mnemonic on your word for that.
may not be.
I don't think so.
Okay, next. A 3-year-old boy is brought to the physician by his parents because of bow leg deformity that has become more noticeable during the past year. He was eight, adopted at the age of 8 months. The birth parents were told that he has hypotonia as a newborn, but no other medical history was provided. He sat upright at the age of 12 months and walked at the age of 24 months. He is at third percentile for height, 20 percentile for weight. Examination show frontal bosom and small nasal bridge frontal bruising and small nasal bridge, and a normal trunk, short limb, increased lumbar lordosis. X-ray show lower extremity metaphyseal flaring, inverted V shape, distal femoral epiphysis, and a disproportionately long fibula. Disproportionately long fibula. The most commonly, the most likely explanation of this finding defect in which of the following?
Jesus. Frontal bossing.
Is it osteogenesis imperfecta?
Is it
Mm,
in the
Don't feel like that,
no? Oh
isn't
my
it?
lord. It yeah, it sounds like it. I mean, hold on.
You are
Oh, no,
fibroblast. Or it is
Jesus speaking.
Marfan. No, no, no. Marfan
Marfan.
is fibrillin, not fibroblast growth factor 3.
Oh, I forgot. Ready?
Why I am not figuring this? Okay.
And okay. So it is fibroblast growth factor. It's achondroplasia. Oh, Lord.
Yes. I
Achondroplasia is
was
the
thinking.
most commonly associated with mutation of FGF3 gene, fibroblast growth factor 3 gene. This mutation of the FBS3 gene causes constitutive activation and downstream effects, including inhibition of endochondral ossification required for development of long bones. Patients with achondroplasia present with macrocephaly, big head with frontal bossing and depressed nasal bridge, short-stature secondary to decreased length of the upper and lower limbs, varus deformity, valgum varus, okay, and hypotonia in infancy. Um, Diagnosis is made based on clinical and radiologic findings. Most gene mutations are spontaneous in origin, although patient can pass down the mutation in an autosomal dominant pattern. Okay, and it's not cartilage. Cartilage oligometry matrix protein is an extracellular matrix protein present in cartilage and may be used as a marker for cartilage turnover. This gene is not involved in the development of achondroplasia. Sulfate transport protein is present in developing and mature cartilage. Sulfate transport protein, as well as several other organs, and is not associated with achondroplasia. Okay. Type 1 collagen is found in bone, skin, tendon, and dentin. Defects in type 1 collagen are associated with osteogenesis imperfecta. Osteogenesis imperfecta presents with multiple fractures following minimal trauma. In infancy, characteristic blue sclera and conductive hearing loss. Bone, skin, tendon, and teeth. Type 2 collagen is found in cartilage, the vitreous humor, and nucleus pulposus. The effects in type 2 collagen have not been associated with achondroplasia. Okay. Okay.
Next,
Next.
a 7-year-old boy is brought to the office in the fall for a routine examination. He has mild intermittent asthma. He has mild intermittent asthma and gastroesophageal reflux disease. His medications are albuterol and ranitidine. Immunizations are up to date when entered the kindergarten. He is at 75 percentile for height and 50 percentile for weight. Vital signs are within normal limit. Examination shows no abnormality. Which of the following is the most appropriate vaccine to administer?
Ready?
Wait 1 second. entered into the kindergarten. Okay,
This influenza. Influenza respiratory is a respiratory viral illness caused by influenza virus or myxovirus that is transmitted via respiratory droplets and causes seasonal pandemic. Symptoms include fever, chills, myalgia, malaise, headaches, nausea, vomiting. Pneumonia may develop. The CDC recommends annual influenza virus vaccination beginning at 6 months old. The influenza vaccine is available as a trivalent or quadrivalent intramuscular injection of inactivated virus or a nasal spray of live attenuated virus. Influenza is a seasonal illness affecting patients typically in the winter and early spring months. Patients should be given influenza vaccine annually in the fall. It's not DTaP vaccine is incorrect. DTaP vaccine is given as a three-dose series, 2 for 6 months, followed by booster injections between like 15 to 18 months and between 4 to 6 years. I don't know how I'm supposed to remember that. So, okay, so it's not that. And it's not Hemophilus type B vaccine is indicated for all children for prevention of infection with Hemophilus. Hemophilus can result in various mucosal infections such as conjunctivitis, otitis media, bronchitis, pneumonia. It was the leading cause of epiglottitis in children prior to widespread vaccination. The vaccine is administered in a 2 to 3 dose series beginning at 2 and 6 months, followed by a booster at like a year old or something. Okay. And he is, oh, he's 7. Okay. All right.
next.
Mm.
A 15-year-old girl is brought to the physician because of 1 week history of constant severe abdominal pain. During the past year, she has 10 episodes of cramp. First episode last 3 months ago. She has no history of serious illness, takes no medication. She has never had menstrual period. She is sexually active with one male partner and uses condom inconsistently. She is at 80 percentile for weight and height. Temperature is 100. Pulse is 120 per minute. Respiration 16 per minute. And blood pressure 90/50. Breast and genital development is sexual maturity rating stage 5. Abdominal examination show moderate tenderness. A mass is palpated in the suprapubic region at the midline. Pelvic examination shows normal appearing external genitalia and lower vagina. The cervix cannot be visualized because of bluish bulging vaginal tissue that obscures the upper vagina. Which of the following is the most likely diagnosis? Which of the following is the most favorite next step in the diagnosis? Okay. Is it hematocolpos?
Probably, yeah. So you do laparoscopy or is it pelvic ultrasound?
I think that pelvic ultrasound is safe.
Pelvic ultrasound doesn't, laparoscopy don't make sense. Okay, let me see. Pelvic ultrasound. Transverse vaginal septum may occur when there is failure of canalization of the vaginal canal, preventing the excretion of menstrual blood. A transverse vaginal septum presents with primary amenorrhea. This is transverse vaginal septum. Primary amenorrhea, cyclic pelvic pain, and bulging pelvic mass in an adolescent with otherwise normal sexual development. Significant accumulation of menstrual blood products may give the bulging septum a blue appearance that is present on physical exam, condition known as hematocorps. Okay. Diagnosis is made by pelvic ultrasound. A transverse vaginal septum is treated with transvaginal incision and drainage with resection of the septum and evacuation of the accumulated blood. It's not laparoscopy. Laparoscopy can be used to aid in the diagnosis of multiple intra-abdominal pathologies. A common reason for paracaryosis endometriosis. Yeah, this patient exhibit none of these symptoms or other intra-abdominal signs or symptoms to justify the need for invasive procedure like laparoscopy. Okay, next. I've never seen that the, what is it called? Transfer vaginal septum.
Okay.
Okay, transverse
Okay,
vaginal.
last. A 14-month-old girl is brought to the physician because of intermittent vomiting for 12 hours. During this period, her playing and sleeping has been interrupted by episodes of crying and fretfulness that lasts 20 to 30 minutes. Over the past hour, she has had two bowel movements, one containing blood. Examination shows no abdominal distension. A contrast X-ray of the abdomen shows no evidence of the bowel obstruction. Which of the following is the most likely diagnosis?
Crying and fretfulness. I don't know what fretfulness means. And she had two bowel movements, abdominal, no abdominal distension, no evidence of bowel obstruction, intussusception, viral gastroenteritis, no, it's blood, volvulus, no evidence of obstruction, mm, appendicitis, intussusception. Between appendicitis and intussusception, or is it dysentery?
Why it is appendicitis? 14
Mm,
month old girl only.
yeah.
There is no fever. There is nothing.
Mm, mm.
And in
So you,
appendicitis usually do not have bloody stool.
yeah, doesn't make sense. So you think it's intussusception?
Intersusception can happen, yes. Because
Mm,
intersusception is like telescoping. So after 20 to 30 minutes, the telescoping may become normal. That's why intersusception is very hard to diagnose. Like
mm,
the baby has pain now, then you he goes to the hospital and then pain removes after movement of the bowel, like bowel movement.
okay. Let's check. You're right. It's intussusception occurs when a segment of bowel telescopes into adjacent segment recurring, resulting in colicky, abdominal pain, nausea, vomiting, and potentially bloody mucous stools. Classically, it presents in an infant or young child with recurring episodes of severe abdominal pain, often punctuated by asymptomatic periods. Intussusception typically occurs because of the presence of pathologic leg point, like vehicle diverticular, lymphadenopathy, structure, malignancy, which acts to draw one segment of bowel into the other during peristalsis. If the intussusception resolves, there may be no symptoms. If it does not resolve, traction of mesenteric vessels can result in hypoperfusion of the segment with resultant inflammation, hemorrhage, obstruction, and pain. It may be detected on physical exam as an elongated mass, often in the right upper quadrant. Diagnosis consists of clinical history, physical exam, and is supported by imaging. Ultrasound evaluation is preferred in young children and will show telescoping interposed bowel segments in longitudinal orientation or a targetoid appearance in transverse orientation. Now, contrast NMI can also show intussusception with appearance of a mass prolapsing into the lumen. um, and an inability of the contrast to reach the proximal bowel. Treatment of ileocolic intussusception requires administration of contrast enema, which reduces the intussusception. Contrast enema is both diagnostic and therapeutic. In this setting, surgery may be required in cases where there is repetitive failure of the enema to reduce the insusception, or if the patient has symptoms concerning with bile necrosis and perforation. It's not appendicitis, typically present with loss of appetite, nausea, vomiting, and right lower quadrant pain. It's often associated with fever and leukocytosis, thus don't cause bloody stool. It's not dysentery, characterized by bloody diarrhea, typically caused by bacteria such as Shigella and E. coli, enterohemorrhagic. This patient has no risk factors for bacterial diarrhea, intermittent episodes of abdominal pain, and it's not mid-gut volvulus typically occurs in the setting of malrotation secondary to incomplete rotation of the bowel during embryonic development. This presents with bilous vomiting, abdominal distension, and pain. And when severe intestinal necrosis, hematochezia, perforation, and peritonitis. Okay,
Okay, we are done.
we are done. You want to do biopsy?